Welcome, everybody. Good morning, good afternoon, and good evening. It is my pleasure to bring you this fantastic virtual panel discussion. But before I say a little bit more about that, let me do a brief introduction. I am Ravi Anupindi. I'm a faculty at the Ross School of Business at the University of Michigan. I also am a co-chair of the group that called the Global Health Supply Chain Summit that brings you annually the Global Health Supply Chain Conference. And last few months, we've also been hosting a series of webinars around important topics that we believe is something that our participants are interested in. So, for example, this is the fourth in the series. The past three webinars focused on COVID in partnership with the Canonics, in partnership with the World Food Program, etc. So today we bring you, we focus on what we may call patient-centric pharmaceutical services and systems, as you can see from the title. And we bring this to you in partnership with experts in this field, which is Palladium, USP, and PICMA organizations. The focus really here would be what we are trying to bring together is leading public and private sector experts from across the pharmaceutical supply chain. And we will explore the latest in advancing patient-centered pharmaceutical services in low and middle income countries, and opportunities to take the discussion from what we have been calling rhetoric to reality. So this is, I know we are pivoting a little bit away from COVID, which is still at the top of mind for many people, but the pharmaceutical systems management is also very important. I am delighted that we have about 215 registrations for this event today. I'm sure people are joining in slowly, representing 38 countries. So this is really very delighted to see such a widespread participation from across the globe. It tells us how important this topic is. I'm just introducing this session. So before I hand over to our moderator, let me just give you a little bit of the logistics of how this event will proceed. The webinar is being recorded and will be posted, among other places, on our website, which is gscs.com. And from there, you'll be able to link to the YouTube channel. As a participant, you may submit your questions for the panelists through the Q&A button that you will see in the Zoom session. And there will be questions. So panelists will present their initial thoughts. There will be some structured Q&A following which there will be open Q&A. But all throughout, as you listen to the panelists, please feel free to type in your question in the Q&A box. We also provide live French interpretation. So for those of you who are listening in on the French channel, you should be able to check on the bottom of your screen the interpretation and select the French channel. So without further ado, now it is my pleasure to introduce our moderator, Dr. and Professor Lloyd Matowe. He's a great friend and a long-term serving member of our Global Health Supply Chain Summit. You could say we are partners in crime. He's a well-recognized name in the supply chain circles. He wears many important and interesting hats. He's a professor of pharmacy practice and dean of the School of Pharmacy at Eden University in Zambia. He currently serves as the chair of People That Deliver initiative that is doing very important work in HR and supply chains. He's also the director of technical assistance at PICMA Africa Limited. And he's also the founder and CEO of the organization called Pharmaceutical Systems in Africa. So I would now hand over to Lloyd to take over. He's going to moderate the session and introduce the speakers. Lloyd, over to you.
Thank you, Ravi. Good afternoon from sunny Lusaka in Zambia. Good morning if you are in the Northern Hemisphere. And wherever you are, hope you're staying safe. And Ravi, thank you for the generous introduction. The session today focuses on access to medicines. And for years now, access to essential medicines has remained a critical challenge for patients in many parts of the world. And to address these, various and several interventions have been necessary and have been alluded to. At the center of this is clearly the patient. So our session focuses on 5 key areas of strengthening pharmaceutical systems. And to help us discuss these are 5 preeminent persons in this area who I will introduce in the area that they will speak. To begin with, we present antimicrobial resistance, and this is going to be presented by Dr. Murphy Mpundu. Murphy is a recognized AMR expert in the Africa region. He's the director of REACT Africa and the partnership and engagement for the Center for Antimicrobial Solutions, ICARS. Is also an honorary research fellow at the University of KwaZulu-Natal in South Africa. And Murphy serves as an external advisor for the board of the Newton that focuses on AMR discovery. That's Murphy for you. The second of our speaker is Neymatu Adjabui, who is a senior program lead for the USP's Promoting the Quality of Medicines Plus program funded by USAID. She started her career in the local pharmaceutical industry in Ghana and joined USP in 2013, where she has worked for the last 8 years. She currently manages regulatory system strengthening across the whole of the West Africa region. She is a pharmaceutical scientist and a certified quality manager. The third of our panelists is Professor and Doctor, a good friend of mine, Alex Dodo, who is the director of the Africa Collaborating Center for Pharmacovigilance. Alex has won a number of awards previously, being the Director General. She is currently the Director General for Ghana Standards Authority and previously served as the Director, African Collaborating Center for Pharmacovigilance. And until 2017, he was the Director of the only second WHO Collaborating Center for Pharmacovigilance in Ghana after UMC in Sweden. And for 3 years, he served as the President of the Global Association for Pharmacovigilance Practitioners. The third of our panelists is Mr. Malon Banda. Malon Banda chairs the Ecumenical Pharmaceutical Network, is currently also serving as the Director of Pharmaceutical Services at CHARS. CHARS stands for the Churches Health Association of Zambia. His central work is advising on medicines procurement within different organizations and his own organizations and supply management systems with an interest in achieving optimum benefit for patients taking the medications. Last but not least is Sunita Sharma, who is the Vice President for Palladium and the Director of Health Policy Plus Project. Sunita has served as director in various programs, including the Health Plus project at Palladium, and previously she served as a director in many other international projects, including the one at Palladium that focuses on health education. She holds a PhD in economics and a master's degree in health management. So, ladies and gentlemen, these are our panelists for today. So without further ado, I will invite the first of our panelists, Murphy Mpundu.
Thank you so much, Dr. Lloyd Matoe, and thank you for inviting me to offer some perspectives on this important issue of antimicrobial resistance. I'll look at the three areas. We know that actually AMR is an existential threat that has resulted from a weak health system and is a great challenge in terms of public health. So when we look at it, is there is a projection that by 2050, there will be 10 million deaths that will be attributed to drug-resistant infections if we do not do anything. And currently, we have around 750,000 people that die from drug-resistant infections, including resistance to actually tuberculosis. I think that's a good starting point. But if you look at it in the context of the deaths that we've had with COVID, I think it gives even more clarity. In the first 15 months of COVID, we lost 2.7 million people. And so if in 15 months, we lose 2.7 people, think about how that scale and the magnitude of this silent pandemic of antimicrobial resistance is going to be. Clearly, effective antibiotics are the cornerstone of basic specialized medicine. And the emergency of bacterial resistance to antibiotics is slowly dismantling our ability to treat infections, alleviate the human suffering, and ultimately to save life. The COVID-19 pandemic is a devastating example of the deadly consequences when treatments and vaccines do not exist that are not available to people who need them. We have had a dry pipeline. We have depended so much on antibiotics, and we've ended up having a dry pipeline. In the last 33 years, there hasn't been any new class of antibiotics. Just within a span of 2 years, between 2016 and 2018, 5 big companies, these are AstraZeneca and the medicines company Sanofi, and there was Sanofi, Novartis and Allergen, all existed from the antibiotic R&D. Merck's buyout of the long-standing anti-infectives company Cubist in 2014 widely was touted as a sign of big pharma re-entry. Was followed, however, by the layoff of 120 researchers and the closure of Cubist in the early stage discovery research unit, which is important. Priority setting, these are the 5 issues I find, fundamentally that are issues. Number 1, priority setting that addresses the most significant and unmet global health needs. Number 2, overcoming the scientific barriers in early discovery research and research phases. Number 3 is the financing late stage and clinical R&D and relying on price and sales revenue of the end-to-end product, but also ensuring sustainable production of quality, procurement and registration on novel antibiotics, and lastly, ensuring a sustainable access to antibiotic resistance. In order to make progress in addressing AMR, there is need to have a paradigm shift to move beyond the understanding and framing of AMR as a medical challenge to one that reflects global inequalities and lack of global prioritization of AMR as a global threat. The ultimate goal should be a systems approach to ensure sustainable access to effective antibiotics for everyone and everywhere, and an end-to-end approach that looks from desk to the patient, looking at the value chain. In the last, in 2020, just last month, WHO released the current R&D pipeline, where we've got 43 antibiotics in the current clinical pipeline, 26 antibiotics that are active against WHO priority pathogens, and only 7 antibiotics are fulfilling the 1+ innovation criteria. But unfortunately, only 2 antibiotics are actually active against multi-drug gram-negative bacteria. Some of the recommendations that we need to look at, number 1 is establishing a global R&D coordination entity with stable and sufficient funding. We need to increase early stage funding for antibiotic R&D and increase the transparency of R&D cost and argument. We need to make sure that the discussions on incentive and new models also include LIMCs and the government, but also ensure that we do not design a global system that are not sustainable. When we look at the resource gaps that are critical, it's critical that we fill the resource gaps that we have, both in human, financial resources, in diagnostics, in guidelines. COVID-19 has showed us that weak health systems cannot survive these challenges if they are actually unprepared. We need to ensure that there's access to nationally relevant data on antibiotic use resistance, and the health and economic burden is hindering a strong policy response. Some of the recommendations in this area include concerted global efforts that are needed to rapidly close these crucial evidence and resource gaps. We need to expand the current misaligned incentives in terms of R&D and fund small, medium enterprise and biotech companies and universities in terms of research. There is need for more collaboration and partnerships by donors to avoid any duplication of efforts. And then thirdly, of course, we need a regional collaboration in many ways. And one of the efforts that could improve access of products, of medicines in many regions, in low and middle income countries, is to think of models like actually food procurement. Because when you look at actually food procurements, you can look at the model of UNICEF, you can look at the models of Gavi. They've been successful in pooling. We are able to actually make informed buying by sharing information. It could also take a form of coordinated informed buying. It could take a form of basically group contracting and central and contracting and procurement. So, it's this is the only way that we're going to change. The current model of R&D is that the companies produce antibiotics on a volume based to maximize on profit. And with antimicrobial stewardship and slowing antimicrobial resistance, it's an antithesis in terms of what the pharma industry currently does. So we need to rethink that and really change the way we look at the whole value chain of antimicrobials, but also antimicrobial resistance as a whole. Thank you.
Thank you, Merfin. Of course, in the whole scheme of pharmaceutical management and access, we cannot talk about access to essential medicines without talking about, the potential harm that meds can do to us if not used appropriately, but also what can happen to humankind if we allow these meds to become ineffective. So thank you. Merfin, I would like to follow up with a question in the 2 minutes that we have. Can you please briefly address, in your experience, as an administrator and a policymaker, what has been the greatest challenge to get the AMR message across to the people? For example, why do we continue to see such a big variance between countries in the West and those in the South with regard to rationalizing the use of antimicrobials?
Thank you so much. That's a very important question, Lloyd. I'll start by saying that the current narrative of antimicrobial resistance or antibiotic resistance is too technical, and it's grouping with resistance to other pathogens within the broader concept of antimicrobial resistance. I believe that the problem and the way forward, we need to take antibiotic resistance and address it. It is much easier to communicate. It is much easier to talk about and convince both the public and policymakers. Most LIMCs, they were supported in terms of developing of the AMR national action plans. If they were supported to develop national action plans, they were making a statement saying that they had they do not have any funds to do that. And so, if you look at the 5 strategic areas of the Global Action Plan, and most of the action plans in Africa and in Asia, in the US, they focus on 5 actually critical areas: raising awareness and knowledge around AMR, it's around surveillance and getting to understand the patterns of resistance and what antibiotic we have resistance to, and also consumption. We focus on infection prevention and control, and you find that in most low and middle income countries, these basic things like actually clean water, access to toilets is not available. We need to focus on ensuring that there is actually the rational use of antibiotics, but also the issues around research and development. I think COVID-19 has further worsened the situation, but clearly telling us that we have failed in messaging as public health practitioners, and it's high time we went back and looked and took the issue of antibiotic resistance on its own and address that, because that's the major issue that most countries are facing, and not the broader antimicrobial resistance has been, it's not a good, it has failed. We have not been able to communicate that well. Thank you.
Thank you, Murphy. And we are aware that you might need to run at some point during the course of the webinar. If you are not there at the end, we would like to thank you for contributing to this interesting discussion.
Thank you. It was a pleasure.
Thank you, Murphy. Murphy did mention in his discussions that one of the reasons why we see issues around AMR is weak regulatory systems. And what can we do to improve this situation in countries where we work? And we have none other than Anema to come and discuss the regulatory system strengthening and its impact on access to quality meds in the constituencies where we work. Nema, please.
Thank you very much, Dr. Lloyd. First of all, I'd like to thank you for moderating this great session today, and also thank Ravi and the Global Health Supply Chain Summit for convening this important discussion. I'd like to start by saying that strong regulation is essential, critical for patient-centered pharmaceutical care, because strong regulatory systems ensure that countries have and implement international best practices in the management of their medicines and their medical products. When you strengthen a country's medicines regulatory authority, you're essentially improving timely access to quality assured medicines available for consumption by patients, thereby helping to protect the population. So when we consider patient-centered approaches for sustainable access to quality assured medicines, we must also consider having a strong, robust regulatory system in place. The way I look at it is the Medicines Regulatory Authority is the first service provider to the patient, as they play a critical role in ensuring the safety, quality, efficacy of medicines before the product reaches the market, and of course, also after. We shouldn't forget that regulators also play a critical role. They're critical to ensuring that medicines that are acceptable to patients and appropriate to their needs are made available. And this is particularly important in some cases. For example, when you look at pediatric formulations that are used in the management of tuberculosis, when you also look at long-acting formulations that are used for reproductive health, and also multi-month pill packs that are used of ARVs, and also other preventive options like pre-exposure prophylaxis for preventing the transmission of HIV. In addition to all this, effective medicines regulation builds the foundation of trust for patient-centered care. I mean, a patient should be able to walk into a healthcare facility and trust that the medicines that they will be given meets all the requirements of quality, safety, efficacy. So in other words, that medicine should have received the nod of the Medicines Regulatory Authority. And why not? Because effective regulatory systems allow medicines to be thoroughly evaluated, competently vetted by regulatory professionals, reach patients faster, and also monitored for safety and quality, so that when there is a problem, and there often is, the Medicines Regulatory Authority can respond in a timely manner to protect that same patient. Together, those 8 essential functions of a Medicines Regulatory Authority that we speak about so much these days, they really do help to foster an environment where patients can seek appropriate, convenient, as well as reliable care that is suited to their needs. Murphy spoke about COVID-19 and the lessons that this has taught us, because we've learned so many things over the course of the last year and more. And one of those things is how important this trust really is. And as regulators on the continent, Africa, and elsewhere have responded to the pandemic, what have we seen? We've seen unprecedented levels of cooperations among themselves. We've seen a lot of information exchange, and we've also seen harmonization. And we shouldn't also forget the initiatives to harmonize registration or regulation that could have major benefits to patients. There are current efforts towards strengthening regulatory systems, such as the African Medicines Regulatory Harmonization Initiative, which is really helping to strengthen cooperation and regulatory practice across the African continent. And in addition to the continental level, at the regional level as well, there are strong regional medicines regulation harmonization initiatives going on. And they're using principles like reliance, allowing regulators to work together and make better use of the limited resources that we don't have. And using principles such as reliance in these efforts also help weaker regulators or weaker regulatory systems learn from more mature regulators, whilst giving them the space to hone in on activities that they have no choice but to do themselves in country, like inspecting distribution channels and also conducting quality surveillance. A few examples come to mind. There's the work that's being done within the East African community, the work that is being done within the Southern African Development Community, notably the Zazabona project. And there's work also being done where I sit within ECOWAS that is being piloted by the West African Health Organization and also the West African Monetary Union, which looks after the Francophone bloc. These efforts, which include the development and implementation of harmonized registration guidelines, the development of other technical guidelines, joint assessments, joint inspections, these all help to speed up regulatory submissions, reviewing technical dossiers, and facilitating market authorization to help put quality assured medicines right in the hands of the patients faster than ever before. So Lloyd, those are my initial thoughts on how strengthening regulatory systems can help to strengthen patient-centered pharmaceutical care services and systems. Thank you.
Thank you, Nematu. Clear, precise, and to the point and on time. Thank you. Two bullet points that I captured in your brief presentation: rigorous evaluation. And in evaluating rigorously, the intent is to protect the patient. And that brings us to our next speaker: robust pharmacovigilance systems for patient-centered care in Africa. So it just dives in to where Nematu left. Professor Dodo, please. I think you are muted, Alex. Please unmute.
Thank you very much, Lloyd, and thank you very much for the invite to this meeting, and thanks to my fellow panelists. I'm very pleased that the first two speakers have laid the ground by discussing first antimicrobial resistance and two, the role of regulatory systems. And it's nice that Nematu, the last bullet point she had, dealt really with vigilance and market surveillance. In the patient-centered system, our interest is to ensure that any safety outcomes that result out of the interaction of a patient with a product is documented to ensure that we have a proactive system to protect patients. I think across Africa, the challenge has been, how do you collect safety data in a consistent and reliable manner and in the way that will benefit public health? The traditional methods which have been used by the World Health Organization and others have relied on passive reporting. But with overburdened healthcare workers, with poor reporting culture globally, and with practices in Africa being very, very variable, it is obvious that the systems that are being used across the globe and which have improved across the globe to be quite weak will not inure to much benefit. So as we move from the rhetoric to the reality, the question is, what types of data do we need in Africa? How do we collect it in a robust way? And how will these pieces of data inure to the benefit of public health in Africa and importantly to patient safety? And I have a few thoughts. First and foremost, we need to collect real-time data from within all our various public health programs. And I believe several countries have done that during the current COVID pandemic. We are collecting data using SMS. We are following up patients by phone. People are sending information. There is online reporting in Ghana and other countries. And we are sharing that data both within the region and also with WHO. If you look at our TB programs, our HIV programs, our neglected tropical disease programs, these are avenues where the patients are in constant touch with the practitioners regularly, and where the avenue for having feedback from patients on their experience with any products we give can be collected. In fact, we like to use the word can be harvested to the benefit of both the patients and society. In addition, looking at the plurality of healthcare delivery in Africa, having CHIPS compound, having traditional birth attendants, having midwives, pharmacies, and other categories of medicine suppliers. Each one of these provides a product to a patient to solve a problem. Sometimes the risk from these interactions will outweigh the benefits. But the only way to know is if each single one of these encounters is associated with an avenue where the patients can come back and inform the practitioner that they had an unwanted, a noxious, or unintended consequence, which can be recorded, which can be reported, and which can be supplied to regulators and public health practitioners for decision-making. In the area of traditional and complementary medicine, I think we've spoken a lot about it, that they form part of our repertoire of arsenal for dealing with patients. For treatment, we will use herbal medicines, either alone or with allopathics. And any collection of safety data must ensure that they pay attention to data coming from traditional and alternative medicine, since these medicines can also interact with the allopathic medicines we take. And finally, colleagues, I would like to discuss one thing. That is, when do we start data collection in Africa? The COVID pandemic has made us realize that there is a need to do business differently. Currently, countries have had to accelerate the rate of market entry. So you have phase 1, phase 2, and between phase 3 and market entry, there's been a blur. We believe that this blur between phase 3 and real life, or rather post-approval, since most of these products are being used under emergency use, provides an opportunity for active safety data collection. It provides an opportunity to follow the first few thousands or tens of thousands of cohorts and get a good understanding of any new intervention in these patients, and recording them to be able to assess whether the benefits of using these products outweigh their use or vice versa. I believe that if Africa, one, uses the IT, which is fledgling, including mobile data and remote data collection, if we start collecting active data at the start of introducing any new product, be it vaccine or medicine, if we pay attention to the fact that we are also dealing with traditional and alternative medicines, we shall get a rich collection of data which can be analyzed to the benefit of the patients. So with these few words, I will say that African patients are our best hope. We need to do it for them. We need to keep them happy. We need to keep them safe. And we need to ensure that all medicines used by these patients remain safe and that the benefits of them far outweigh any risk they might pose to themselves individually and to public health in general. Thank you.
Thank you, Professor. Quite precise. It's short, but the message, has gotten through. You mentioned the issue of data and access to data. And in today's age where we are in Africa with access to telephones and social media, there's no reason why we cannot collect the data that you speak of. Go down to whatever village level, in whatever country, you find somebody holding a mobile device, a telephone. So we hear you, and it does fit well into the discussions today. So, for example, you spoke about, the COVID and hesitancy. How can we use data to provide information to people that's needed for policymaking and decision making? So we have had, ladies and gentlemen, we have had 4 antimicrobial resistance. We had, regulation systems. We have had 3, and we had patient safety. And in addition to those 3, at the core is good practice. If we are able to do things correctly and in the proper manner, then some of the issues that we have heard from the first 3 speakers may not occur. So to speak about practice and how we can do things differently is Mr. Marlon Banda, who is going to talk about promoting good pharmacy practices at the point of service. Mr. Banda.
Thank you very much, Professor Matowe. Let me just acknowledge the previous presenters. What they have done is laid a very good foundation for what I have to say. Because when you talk about medicine, it goes without saying that medicines represent one of the most important tools that we have to fight disease, and indeed one of the most important tools that is available to public health. Now, in good practice, the aim is to ensure that the people that use the medicines reap the most benefits from these tools that are available to us. Now, we started with Dr. Mpundu talking about AMR, antimicrobial resistance, which perhaps is an area that demonstrates better or more than any other what happens when we fail in pharmacy practice and we are not practicing as we should. Now, pharmacists are specifically educated and trained to engage in appropriate efforts to assure that medicines are used safely and that they are used to achieve their intended efficacy. The goal of pharmacy practice, therefore, is to contribute to health improvement and to help patients with health problems to make the best use of the medicines, as I have said. Now, there is often a gap between the proven efficacy of medicines that is demonstrated in clinical trials and in drug development, and then their actual effectiveness in practice. And this gap exists because quite often the way that medicines are used or applied is not as intended. We do not follow as strictly, as closely as we should in how the medicines are used in the end. And so we lose out on some of the benefits that we might reap from medicine. So the pharmacist provides first access to quality medicines, and regulation is very important in this area. And then we also provide access to trained health professionals and care. Now, this is particularly my focus in my thoughts in this presentation, because medicines, just the molecule, cannot be used correctly without information. And there is ample evidence that medicines and the dispensing of medicines should be accompanied with counseling and advice to ensure that those that receive the medicines reap the best benefits from the medicines, and that they use the medicines safely Now, unfortunately, in the advent of big public health programs, such as the ones that address HIV, TB, and malaria, which have attracted millions and millions of dollars, there's been a shift away from pharmacy practice per se to a focus on just access, and access being understood as processes that deliver at a large scale these public health focus products such as antiretroviral medicines or TB medicines or antimalarials, to the neglect and to a very significant degree to a focus on how the medicines are given out, which is the essence of pharmacy practice. So there are 6 components to the goal of achieving the best benefits from medicines. First, we have to have ready availability and accessibility of the professionals to the patients, because it is these trained professionals with specialist knowledge that translate and interpret and communicate what the medicines are for.
Mr. Banda, have we lost?
Benefit intended, patients take them. I'm lost? Oof. Hello? Am I back?
You're back. Please continue.
Okay, it's my internet. So I was going to share something I saw. Some patient comes before the doctor, and the doctor asks how she is doing, and she's not doing very well. And the doctor asks, have you been using your inhaler regularly? And she says, yes, like clockwork. And then he says to her, can you demonstrate how you have been using it? And then she gets upset and asks the doctor if he thinks she's stupid. And then he says, okay, just show me how you use it. And she takes out the inhaler and sprays behind her ears, demonstrating very clearly that whoever communicated, dispensed this inhaler to her, didn't give her appropriate information for her to use that product correctly. So this first component of ready availability to patients, even without appointment to pharmacists, is critical. And this is something that, my time is running very fast, but this is something that has been undermined almost completely by COVID because of the need for social distancing. And then other areas are health promotion, okay, I need to cancel this. Assuring effectiveness of medicines, preventing harm from medicines, making responsible use of limited health resources, and so on and so forth. So there are specific areas of expertise that we need to invest in and inculcate and develop that promote good pharmacy practice. Pharmacists should have input in the decisions about the use of medicines. And then secondly, pharmacists should be there to provide the counsel that's necessary for proper administration of medicines. And lastly, these experts should be readily available to communicate the knowledge, but also to make sure that there is adherence by patients to prescribed treatments. And this means that they need to understand medicine to medicine interactions. They need to understand medicine, food interactions, and adverse medicine events, and so on and so forth, which things, if not addressed, undermine good pharmacy practice and adherence to treatment, and in the end lead to suboptimal benefit to patients from these interventions that are critical and are very useful and very effective if taken appropriately. So I'll pause my thoughts there and see if there are questions in discussions, and we can come back and discuss some of these themes in more detail. So, Professor, I'll pause there. And
thank you, Marlon. Thank you, Mr. Banda. What I hear you say, in closing your discussion, is without appropriate practice, all the investments we are getting in saving the patient is lost. And of course, talking of investments, without those investments, we are never going to have the meds that we're talking about. So let's talk financing. How do we remove the financing barriers? And to lead us in this discussion is Sunita. Sunita, please.
Yes, thank you for the opportunity to discuss financing health commodities and medicine. Health commodities are essential in the delivery of effective health services. The credibility of any health system and financial protection of vulnerable populations depend on them. So first, I would like to discuss some of the challenges facing the sector from a financing viewpoint. Uncertainty in financing and over-reliance on external support to procure health commodities and essential medicines impacts the provision of healthcare in most low and middle-income countries. This problem is further amplified by insufficient coverage of essential medicines and commodities where out-of-pocket payments for pharmaceuticals remain a challenge for individuals and families. So WHO estimates that up to 90% of the population in low and middle-income countries purchases medicine through out-of-pocket payments. And medicines account for 20 to 60% of health spending in low and middle income countries. Given the pressures on government budgets, insufficient financing remains a significant challenge to ensuring access to health commodities. So then we ask, how can countries ensure the uninterrupted flow of essential medicines? So there are three areas where the issue should be discussed: improving efficiencies, mobilizing new resources of financing, and implementing a financing or resource allocation strategy that emphasizes access, equity, and quality at its core. So I'll touch on each of them briefly. So for improving efficiency, so creating efficiencies in the use of available resources in the pharmaceutical sector can take the shape of operational, therapeutic, or governance efficiencies. So operational efficiencies can be brought about by improving our operational and procedural practices. Supply chain operations provide a fertile domain for improving efficiency. The adoption of improved procurement practices, policies, and procedures, including generic-based procurements, simple tendering processes, and improving price transparency can bring about great efficiencies. Therapeutic efficiency that reduces cost and waste, mainly by improving clinical practices at the point of services, such as following standard treatment guidelines and good patient information to mitigate potential wrong use of medicine. So countries should also prioritize improving governance and regulatory oversight of procurement agencies. Examples include setting policy for markup across the supply chain system and adopting pooled procurement practices wherever feasible. Resource mobilization. As we know, external direct funding support continues to decline. Countries should evaluate options to further mobilize domestic resources and increase the financing envelope for essential medicines. Expanding funding sources has the added benefit of creating a much needed bridge for new actors, such as individuals and corporations, through a variety of organized pool arrangements. So to achieve this, it is essential that countries understand their macro fiscal environment and the physical space available for sustainable investments in the overall health sector and commodity procurement. Identify the different options available for mobilizing domestic resources to achieve the goal of increased and sustainable financing. Identify financing mechanisms they can utilize, their impact and long-term viability of each of these mechanisms. There are a number of financing options ranging from the trust fund, bonds and risk pooling schemes to investment funds and co-financing models to development impact bonds and advanced market commitments. Clearly, not options are work for each country. It's really ministries of health working with ministries of finance to explore the various available options and expand the dialogue outside the government to include other sectors and stakeholders. For example, co-financing arrangements exist for immunization, HIV, TB, and malaria, managed by Gavi and Global Fund. These arrangements have proven effective in motivating recipient countries to progressively increase the share of medical commodities covered by domestic funds due to the existence of the external financing initiative. To date, there are 2 co-financing models have been employed for family planning and commodity procurement in select number of countries. First is a challenge initiative, which operates in 94 cities across 11 lower and lower middle countries and requires recipient city governments to co-finance annually increasing shares of FP program costs over a 5-year period until they assume 100% of family planning program costs in the final year. The second is Fix 2, which is managed by Ouagadougou Partnership, operating in 9 Francophone West African countries and pays $2 for every $1 prior year increase in conducting or increasing FP commodity costs covered by the government. So USAID funded HP Plus project is conducting an assessment to identify and sketch the contextual conditions that could eventually form the crux of global financing policy for family planning, and will also be estimating the impact of different combinations of these contextual conditions on the volume and domestic resources mobilizations. And finally, a few points on resource allocation approaches. Protection against increasing cost of medicines cannot be resolved without addressing the issue of the broader level of health system. Countries should adopt approaches for financial protection by increasing access to medicines through risk pooling schemes. But since this may take time to implement at the scale required, government should examine earmarking a portion of the budget for pharmaceuticals to address priority health problems and target to the most needy populations. The rationale is that expenditures toward primary health care as opposed to secondary care will have a better yield in terms of reducing mortality and morbidity, and thus resulting in increased productivity. So expanding access by extending medicine benefits under different government-sponsored health insurance schemes is another option for governments to examine. The medicine package will require a phased introduction depending on the richness of the content, as fiscal risk is often determined by the breadth and depth of the benefit package. So I have covered a lot here. As you see, there are many avenues countries can explore for financing health commodities that address issues of access and quality. And I'm glad to answer any questions. Thank you very much.
Thank you, Sunita. We will go into question and answer session in the next 2 minutes. Let me use this last minute, 1 minute, to just summarize the key take-home messages from our panelists. And thank you, very clear, very complex and important topic for discussion. From the first presenter, he spoke about the need for a paradigm shift and to end with regard to intervening on antimicrobial resistance. He also spoke about collaboration, the need for different entities to work together to combat, antimicrobial resistance. Neymar too spoke about the need for a systems approach to strengthening regulatory systems. And she went on and mentioned the 8 points from WHO that helps country to achieve this. And she said the system to strengthen regulatory systems, there's need for integrated approach, integrated in the bigger scope of things that looks at pharmaceutical management in totality and not in isolation. And then she also emphasized on market surveillance and vigilance. Professor Dodo spoke about real-time monitoring, active monitoring of what's happening on the ground, not passive surveillance. And he stated clearly the need for data and how data can help with the decision-making process. And he qualified this by availing electronic records that help us with this data collection process. And Mr. Banda spoke about the need for providers like pharmacists to help with the decision-making process. And he spoke about the right time to help improve on the rationality of use of the medicines at the service delivery point. So he spoke about how can we improve the administration of medicines at the service delivery point. And then he emphasized the need for accurate and correct information to patients at the service delivery point. Last but not least, Sunita spoke about financing, and one key take-home point that came from a presentation is the need to balance, what we need and what we have in terms of resources. We may be ambitious. If you don't rationalize the needs, we might not get anything at all. And to qualify that, she spoke about the need to use our resources wisely. And finally, enhancing the public sector, the public component, the governments to avail more resources for use, for availing the much needed medicines to our population. With this, I'll go straight into our questions for our panelists, not necessarily in the order that you spoke. Neymar too, I'm going to start with you. Your question is, how are regulators and others working in regulatory system strengthening, working to shape systems in a patient-centric way? And for the purpose of our audience, can you give us an example of how strong regulatory systems are helping to foster trust in patients?
Thank you, Lloyd, for that question. Regulators and those who work in regulatory systems strengthening, they're doing this by developing and adopting strategies and approaches that really seek to optimize regulation and ensure timely availability of needed and appropriately quality assured medicines to patients. So this could be through principles like reliance, which I spoke about. It could also be through risk-based approaches to various regulatory functions, like risk-based approach to market surveillance, targeting what is at most risk, risk-based approaches to inspections, and even risk-based approaches to laboratory testing. In addition to that, regulators are also doing this through using integrated regulatory information systems that really allow them to more quickly and effectively evaluate the safety and effectiveness of medicines. The pinnacle also of medicines regulations harmonization efforts on the African continent, as we know, is the establishment of AMA, the African Medicines Agency, which will, as one of its mandates, coordinate the regional harmonization systems and ensure effective medicines regulation, thereby also meeting that fundamental need that we're talking about, that fundamental need of patients accessing needed and appropriate quality assured medical products faster than ever before. And you asked for an example of how strong regulatory systems are helping to foster trust. Perhaps I can delve into what we're all going through right now, this same COVID-19 pandemic that is refusing to go away. That has really shown us again how important trust is in combating pandemics. And as my fellow panelist Alex mentioned, pharmacovigilance is a critical component of regulatory systems and has really taken on more importance in this era of COVID-19, as we've seen with the rollout of the various COVID-19 vaccines. So strong PV systems and then strong post-marketing surveillance systems helps to assure patients. It gives them the assurance and gives them that trust in the safety and quality of products that's available to them. I hope that answers your question, Lloyd.
It does. Thank you, Nematu. Thank you. Very, very clear. I think he did come out very strongly about assuring the patients, assuring the constituency. And I did, yes, Professor Dodo did allude, we'll come to him in a short while, did allude to what you just been speaking about, the hesitancy. It's because patients have no trust. They don't believe. And no more than today with social media, than that is needed now more than ever. People have access to anything and everything, anywhere at any time. So thank you for that. Sunita, I'll come to you next. The question I would like to ask you, you did speak, in detail on what needs to happen to have continued access to health commodities in terms of financing. And given some of the discussions so far, mainly from you, where do you see opportunities to bring the private sector on the table and engage them on patient-centered services?
Yes, so thank you very much for your question. Actually, private sector has a very, very important role to play, and government engaging them as partners in addressing this challenge. So it's all about like engaging them in policy discussions, creating conditions for greater engagement in terms of market entry, functioning well in the market, and market growth. Also, all those aspects are very important. So when we think about pool procurement, or we think about really improving efficiencies, contracting out to private sector can be an option. Thinking about estimating what are the needs and who is going to fill what requirement are important aspects of it, including we think about mobilizing private capital is an important angle. We all need to think about it. So creating platform for dialogue discussion, really looking at data together, looking at what the needs are, what role each of these sectors can play. Those are important aspects, and there are different financing instruments are available for public and private sector to work together. So for example, the Africa Medicine Impact Investment Fund is an innovative purpose-driven investment vehicle that delivers social and development impact by increasing access to affordable, good quality medicines and diagnostics in sub-Saharan Africa. The fund provides capital for initiating and scaling up regional pharmaceutical marketplace loans at market rates to private sector enterprises, with the goal of increasing access to medicines and healthcare in the region and commercial sustainability. We have seen a number of models as well, public sector providing low-cost medicines to private sector, really looking at different options to really have better access for patients, as you're saying, patient-centered design. I think that's a really important aspect of it. Thank you.
I hear you say the the public sector cannot do it alone. And that's in essence the truth. That we need each other. We need the private sector to come in, but the private sector, they are meant to make money. So governments need to be able to provide conducive environments for businesses to flourish. And then while businesses are flourishing, then you do provide the social services that we're talking about. So thank you for that, Senator. If we have a little bit more time, I'll come back to you. For now, I would like to move on, and I'll move on to Mr. Banda. Mr. Banda, follow on to your presentation. I would like to ask the question, based on the COVID-19 pandemic, and you did allude to it. So the question is, from the COVID-19 pandemic, what do you see? What do you see as the importance of ensuring the rational use of medicines during the given environment? I'll qualify my statement. From your experience of working in resource-limited countries, do you have a sense that the use component, we talk of the pharmaceutical management cycle, that is different components, and one of those components is the use. Do you have a sense that the use component of the medicines management cycle has been neglected? How can we bring back the focus on the rational use aspects and tie that up to support patient-centered care? It's long, it's a mouthful, but I'm sure I've captured the essence of my question.
Indeed, a mouthful, Professor, but very apt and very appropriate question to ask at this time. As you have said, COVID has taught us a number of things, and one of them has been the need for us to emphasize the use place in the drug management cycle. Again, as I indicated earlier, over the last 20 years or so, there's been great emphasis on all the other aspects that ensure that there's delivery, there's availability, there's access, physical access to medicines at point of care. But there's been very little done to promote the use and to achieve appropriate use of medicines. And this has been exacerbated by the social distancing requirements of COVID. Let me say something more. It is not unusual in resource-limited settings to find that the most qualified people in the pharmacy are doing supply chain as opposed to interacting with patients, counseling patients, advising patients. And this is very well if the treatments are not complicated, but I cannot see, one that I can say this is not complicated and it's easy enough. In my experience, one is inundated with many, many instances and examples of misuse, inappropriate use and application of medicines, because the most qualified people are not immediately engaged and interacting with patients. How can we bring back this focus? I think at various levels, at global level, where partners are supporting big programs, public health programs, I think there's need at that level for financing that addresses this component of supply chain. We need to go back to promotion of the rational use of medicines. And I think we need support. And this support will address the training needs, pre-training of pharmacy professionals. Unfortunately, again, what one sees, what one experiences in resource-limited settings is that even pharmacy schools are taking on wholesale the concepts of supply chain and are emphasizing those because they are attractive, they are providing employment, they are providing career progression channels. But what I'm saying is that there needs to be deliberate refocusing and funding for the rational use of drugs in order for these medicines that are available to be achieving what they should. The second is what I've just alluded to. There needs to be a greater focus in training. So resources, and then in training, the universities need to go back to this, to clinical pharmacy, to bedside pharmacy, to dispensing, appropriate use of medicines. So I think doing those things and perhaps re-emphasizing them and speaking about them as central to pharmacy practice will start to redress this imbalance that's been created. Thank you, Professor.
Thank you, Marlon. So in other words, you say if medicines are not used appropriately, then they are in essence, poisons. They're not medicines at all. Exactly. So we do need to focus, refocus on how to use them appropriately. Professor Dodo, Neema, yourself and Mr. Banda spoke of the phrase trust, patient trust. So speaking of building trust, there's been a lot of discussions around how to build patient trust in COVID-19 vaccines. As a leader and manager and an opinion leader, with your extensive experience in this area, how best can countries in resource-limited settings respond to safety concerns regarding the various COVID-19 vaccines? What current strategies, Professor, are already in place to address vaccine safety concerns in Africa?
Thank you very, very much, Lloyd, for this question. I think in essence, the work we all do is about engaging communities to ensure that the good advice we have for them and the good interventions will be taken on board and utilized. For Africa, I think the Ebola crisis of 2014, 2015 served as a very, very useful learning point. Indeed, arising out of the Ebola crisis, we, together with the London School of Hygiene, started developing this vaccine confidence agenda. How do you build confidence in people? How do you build trust? One of the key things we realized was, one, being open and truthful. Simple as that may sound, I think we realized that we are dealing with different communities. Even among experts, you are dealing with scientific communities, you are dealing with regulatory agencies, you are dealing with academia, you are dealing with the media, all of whom come with different agenda. I mean, we may assume that the interests are the same, but quite often they are not. So what have we done and what has worked? With COVID-19, we were lucky to have a recent experience. That was Ebola. In Ghana, we got it wrong. The communication to policymakers, to politicians and the like, shall we say, didn't go well. So what did we do? In 2019, we wanted to roll out the malaria vaccine. We engaged Parliament, for starters, because policymakers needed to be educated and engaged. We engaged the media. Indeed, we took the view that a longer engagement of society prior to rollout of any intervention is better than the rushed engagement. So we delayed in rolling out the malaria vaccine. It took probably more than a year, close to 18 months. With COVID-19, we realized that we are living in the social media age. WhatsApp is very notorious in spreading information. So the government of Ghana, as a policy, took on the view that communicate from the highest level. The president took the lead, and he has been very, very consistent. Then when it came to the technical agencies, the briefings are regular. The COVID-19 website page is up, even for the vaccination. Leadership started. We were given real-time data, including how many are vaccinated. And to ensure that everybody is on board, we had a COVID-19 vaccine safety review committee, which regularly updates the country on all events, serious and non-serious. And we have learned from this process that rather than people being afraid, they are assured. Patients have a right to be concerned, but I believe policymakers and leaders have a responsibility to provide assurance in the systems we have put in place to give them that assurance. And those systems must be open and transparent, and patients should be able to access them regularly. And I believe when we do that, we will go a long way to keeping patients assured. We will never solve it 100% okay, but we will solve it in the sense that it's an ongoing communication with patients. As the media for the outlets of communication increase, so will patients' expectations and demands. And as you reach out to them, you may have feedback. Occasionally, you may need to change the messaging. But I think the key message is keep on giving information, be reliable, be consistent, be open, and be transparent. And last but not the least, let us trust the patients. Because at the end of the day, it is their body. It is they we need to work together with us to improve public health. And trusting and respecting them really is the fundamental basis for building trust in any system. Thank you.
Thank you, Professor. Thank you. I hear you in your last points on that question. It's about trust. It's trust back. We trust the patients, and they trust us back as policymakers, as administrators. And you also did, in this era of social media, there's just so much misinformation. So being able to sieve what's fact and what's fiction, is critical in getting the messages to where it's needed. Ravi, do we have any questions from the Q&A for the panelists?
Yes, thank you, Lloyd. Thank you, panelists. This has been great. I've been watching this, so there have been some questions. So one, and I don't know, it's not addressed to a specific person, but there was some discussion about private sector involvement. Could somebody speak to, say, non-traditional partners? And there's an example saying, for example, using telecom companies for free text messages to communicate with the patients, etc. So are there other examples of some of these non-traditional partners you could think about to involve them as a private sector? So that's one question. Let me say that. Let me add another question also, and then you can respond collectively. The other question is around disposal mechanism. So far, discussion has been going from entry into the country through regulatory processes, et cetera, and going all the way up to the dispensing of medicine. But what about disposal of pharmaceutical waste and from both the community and healthcare facilities? So there are other questions, but these two I'll just pose right now and have whoever wants to respond. Yeah.
Lloyd, are you choosing any of us, or can we jump in?
Please jump in, Professor. Yeah, any one of you, please.
So I have two short answers. In the use of telcos, I hope the participants will be pleased to know that one of the telco giants in Africa, MTN, actually led in the procurement and distribution of vaccines for countries. They acquired the vaccines and gave it to national governments to distribute as needed. And in so doing, obviously, they have come into the fray. And they have, in Ghana and a few places, provided their platforms for messaging on COVID-19. So it's something which is ongoing, but they are not just providing their platforms, they are actually providing support in terms of helping in the acquisition of vaccines, diagnostics, as well as personal protective equipment. In relation to the pharmaceutical waste, I think it's a topic that I hope other panelists would address, but it's a big one. We are trying to address it by having standards for which companies can dispose of their waste, because we have solid data that shows that our environment in Ghana is heavily polluted with waste of all kinds. Over.
So who wants to pick up on the pharmaceutical waste? Anybody has any thoughts on what can be done? Maybe Marlon? Sorry to put
Yes,
you on the
Mr.
spot.
Banda or Nematu, anybody wants to pick up quickly on the waste in addition to what Prof has added?
Maybe before Marlon goes, I think I agree with what Alex was saying. We really don't have standards. It's a big problem, and I don't think we have all the solutions here now. The discussions are ongoing, and hopefully, as time goes by, we'd have the standards and then solutions, because it indeed is a huge problem. Thank you.
Yeah, so waste is a very broad topic of discussion, starting from planning of the needs, which, if not done correctly, precipitate waste. But I think it falls squarely in the regulatory area, because without regulation, then people would do things that are harmful. So in developing countries, there's more and more discussion of regulating waste from the point of view of pharmaceutical waste, but also from the environmentalists to preserve the environment, or to keep away harm from the environment. I think that systems should develop, and I think at the core, this is what I'm saying, should be regulations from which you have guidelines, so that people know at planning stage, at use stage, and at disposal stage what to do to prevent, and then what to do when they need to dispose. And I think that, secondly, partners who are affording us support in resource-limited situations should also think about this and make special provisions to enable us to invest in infrastructure that enables disposal in a way that is least harmful.
Yes, I would also like to add about this private sector engagement. Like I've seen in India, very successful arrangement where that markups on medicines are so high. And especially for when we think about the poor or lower middle income families, it's like they become poor because of these medicine expenses, because of expenditures and all those things. So government of Rajasthan, actually, they looked at in their hospitals, they created this unit, and which was, they contracted out to private sector just to manage, but they directly got generic medicines from pharmaceutical companies. And that really helped a lot with like 40% and like big reduction in prices. So people can go directly to those hospitals and get medicines. They don't have to go to pharmacies and pay very high prices. So that was one of the things, a very successful public-private partnership where private sector was managing it. And overall, it was like government's direct engagement with pharmaceutical companies to reduce cost for the patient.
Yeah, thank you, Sunita. I actually had a couple of questions, one around regulation. So, Mr. Matu, you spoke about regulatory harmonization. And one of the questions that was coming through my mind is that there is the regulatory activities to get access to medicines for a particular company, brand coming into the country. That typically is a revenue activity, because countries would charge certain revenue for that process, whereas downstream market vigilance for safety, efficacy, et cetera, what's going on, becomes a cost activity. So when we talk about, for a country, right? So when we talk about harmonization, if you think about in terms of what you say happens in Europe, say, EMA, once EMA approves, then every country picks it up. So if you think in terms of like, it's harmonization, not that every country duplicates the input process in terms of getting access, How do you get around that fact? Because one is a revenue generating activity, the other one is a cost activity. So does that put some worry about how that barrier will be crossed? That is, let's suppose whether it is Eastern Africa or Southern Africa kind of collectively doing approval, but then you take away the revenue for each country. So how would that barrier be crossed? So that to me is kind of some tension. I don't know how that could be resolved. And let me say the other question, Sunita, perhaps to you. You talked about various types of financing. One thing that comes to my mind is financing of working capital for the pharmacy or shops, because their constraints on working capital inhibits them carrying sufficient stock, right? And so there is another part of financing in the supply chain itself. There's a financing of the health systems and all that stuff. So yeah. Anyway, yeah, those are my two questions here.
Thank you, Ravi. I think I'll go first and then Sunita can jump in. I think it's an interesting point that you bring up. And these discussions are still being had because it is a real concern for the medicines regulatory authorities. You charge a certain fee for the registration of medicines. And now when you're to jointly assess, then is the manufacturer going to pay each and every country a fee for their products to enter into that market? And for now, that is the response. The manufacturer would still have to pay that fee for that registration for having their product to enter that market. I think when the African Medicines Agency really comes on stream, and we're eagerly waiting for that to happen, I think all these would be streamlined, and we would have to make sure that the medicines regulatory authorities are not losing out on the revenue they need for market surveillance and vigilance as well. Thank you.
Thank you.
So what we are doing currently in Liberia, for example, we are working with banks and as well as with small clinics, because especially similar way, the pharmacy, they also need working capital. And so they are, microcredit loans, very, very low interest rate, and all of those things, those arrangements where they can really deliver services or have all those inputs available, supplies available. Similar kind of arrangement can also be done for pharmacies. I think number of options we can look at, because those arrangements can, it has worked so well, even reaching poor communities and providing low-cost loans, and that similar arrangement for pharmacies, because this is a big issue, out-of-pocket expenditure and making good medicines available for people when they come to pharmacies and low cost. Thank you.
Ravi, you're
Lloyd, 3 minutes to the end. There are one or two more questions, but I don't know if you have the time or you want to, go through closing comments from the speakers.
Oh, I think we can close, Ravi. Yes.
Yeah, okay.
We're short of time. So look, very quickly, I'll start with you, Sunita, in 30 seconds, one final thought.
I really want to emphasize that out-of-pocket expenditure medicines is very high. We need to have patient-centered, really how we help patients. In that, we can work on all different fronts: financing strategy, mechanism, resource mobilization, and also efficiency. We can spend our resources wisely and really look at how we can maximize resources overall to provide low-cost services or medicines and commodities to everyone, like patient-centered approach. Thank you.
Thank you, Sunita. Professor Dodo, final thoughts in 30 seconds.
My final thoughts are that safety is certainly the biggest consideration for patients when they undergo healthcare. They want to be well, but they also want to be sure that they are safe. And I believe that all our activities should be aligned to harvest safety outcomes, whether at the pharmacy, whether at the clinic, whether at the midwives. And as we harvest this into repositories or databases, which can be shared, we will be able to provide feedback to the patients and give them confidence. In so doing, we would maintain the trust that they build in us by coming to us in the first place for solutions. Thank you.
Thank you, Alex. Nematu?
Yeah, I think I'd still touch on the trust. The patients should be able to trust that whatever they're being given, what they're getting access to is of the right quality. And in order to do that, they need to believe that their regulators are armed to be able to put or ensure that what goes on the market is what is good for them. So whatever we do, when we're thinking about patient-centered care, let's also think about the regulators, how we can strengthen and arm them so that they're able to do their jobs more competently. Thank you.
Give them the weapons so that they will be able to. Marlon, 30 seconds. Thank you, Nemat.
Thank you very much. I think for me, my last word would be to advocate for a return to a place where we emphasize efficacy of medicines in use. Everything falls down. Everything is a waste of resources if in the end, medicines are not achieving their intended purposes. We see this in AMR, and we're losing a lot of money. We're losing a lot of lives because we are not investing sufficiently in this area of supply chain. So I would advocate that we start again with strategies that meet this goal, towards this goal of achieving the best value for medicines in patient use. Thank you.
Thank you. Thank you, Marlon. Thank you. Ravi, over to you.
Yeah. Thank you so much, all the speakers here. Alex, Sunita, Marlon, and Nematu. I hope it's okay to call you by your first names. It's been a fantastic discussion, and also of our first speaker, Murphin, who had to step away. And fantastic job, Lloyd, for moderating this and bringing together the end-to-end perspective. Really appreciate that. And I learned a lot, and I hope the attendees are as well. I'm sorry we couldn't get through all the questions, but hopefully this was a very educational experience for you. I just, before I close, just wanted to remind you that recording of this webinar will be available, and we will send this link also to all of you via email. Once again, thank you for attending this webinar. And please stay safe and healthy. I know times are really challenging right now. So thank you so much, and goodbye.
Thank you very much. Goodbye.
Thank you, everybody. Thank you, panelists.
Thank
Goodbye.
you. Bye-bye.
Bye-bye.
Bye-bye.